Juliana Boyle, and I'm your host for today's second of 3 webinars on Community Paramedicine, Show Me the Money, Financing for Community Paramedicine Program. This 60-minute webinar is presented by the Abaris Group, a consulting firm that specializes in emergency department, trauma, and EMS strategic planning, program implementation, and financial analytics. We have an excellent session for you today and are glad you've joined us. We've structured this 1-hour webinar with 30 minutes of discussion by our experts and then 30 minutes to answer your questions. Our presenters for today's webinar are Matt Zavodsky and Mike Williams. Good morning, gentlemen. We're looking forward to your presentation, but first let me quickly go over some housekeeping issues. Please feel free to submit a question anytime. To submit a question, type it in the designated questions area in the control panel and click Send to submit. We won't answer questions over the audio system. We will answer questions over the audio system and not on the computer screen. And don't worry, those questions that are not answered during the webinar will be answered, and a copy of the Q&A will be sent to everyone. Now let me tell you a little bit about our speakers. First up is Mike Williams. Mike is the president of the Abaris Group and has 30-plus years of operation and design for emergency care systems. He is a specialist on health reform with respect to pre-hospital, outpatient, and inpatient services, and on regional delivery of systems at the safety net and traditional payer levels. He recently completed an assessment on health reform for the Sacramento County region, assessing its impact on primary and emergency care services. Also joining us today is Matt Zavodsky. Matt is the Public Affairs Director at MedStar Mobile Healthcare in Fort Worth, Texas. MedStar is the exclusive emergency and non-emergency EMS provider for Fort Worth and 14 surrounding cities in North Texas. Matt has helped guide the implementation of several innovative partnerships with healthcare partners that have brought MedStar fully into the healthcare system. Okay, now let's get started. Mike, I'd like to turn the floor over to you.
Well, thanks, Juliana. Excellent, warm welcome. And I want to thank all of you who are here. It looks like many states are represented, and there's multiple entities represented here. And I mean by that, not just ambulance providers or mobile health providers, potential mobile health providers, but public and private. And there's even, it looks like, a number of EMS agencies and consulting firms. There seems to be a lot of interest in this area. This is the second of our 2 webinars. And this one, I think people are particularly interested in because this is where the dollars are, and where you know, there's a lot of hunger and a lot of information needs about where do you get the dollars to afford this piece of the action. Matt, welcome to you and your involvement today as well, being a good partner for us.
Thanks, Mike. Nice to be here.
Now, one day, you know, we're going to walk through here, and I'm going to indicate how we're going to do the presentation. This is a 30-minute presentation up front, and then a 30-minute question and answer. That time is really your time. So we have some questions in hand, and then we've asked if you have additional questions, you'd let us know what those are. There's no handout for this because it's pretty hard to prescribe to you what your questions are going to be. And as you'll noted, our early part of this conversation is really just a conversation between myself and Matt and their history at MedStar. So we've done the invitation. You can see by the outline slide that I have in front of you. We're going to now begin the conversation with Matt, and then we'll take another 30 minutes of questions and answers. Matt, are you ready with this?
I am ready when you are, sir.
All righty, let's go to the first one. Oh my gosh, so complicated. What were your basics?
Well, you always have to start with a strong foundation. And when, from a financial perspective, when we went into this process, our financial value, if you will, was the resources that we were consuming responding to calls that we could probably prevent. MedStar had struggled for quite some time with some performance issues and good response times, and then certainly struggling with the cost of personnel and having all of those resources on the street, and also looked at some of the payer mix for some of these patients that were accessing our service and realized that maybe there's a better economic model here that will help us make our resources used more efficiently and be able to guide the patient to the right location. So from the basics, when we first looked at this from a financial perspective, it was, are we going to save enough money to spend on addressing the frequent EMS users? When we did the analysis, there was a small gap there. We figured, okay, we can probably reduce some positions, and we were able to do that, actually. The first fiscal year after we started doing the program, we were able to reduce some positions from our budget. And we were also able to generate some additional revenue by having those community paramedics initially also certified, credentialed to do critical care transport. So we generated some critical care transport revenue that we had never done before, because that was a new service delivery model for us. And the reduction that we had in some of the payroll costs for the first year made that process relatively budget neutral. As we moved on, you can only cut those positions from a budget once, so the economics had to change. But that was the basic approach, that the financial analysis that we used going into that first year of the program.
Well, great. So having that strong foundation is really critical. And then we learned during our first session that really having the place where the hockey puck goes, right? Really having a goal, what you attempt to do, and the numbers may look fantastic, it may look awful, but if you're not getting to where you want to go, it really doesn't matter as well, and maybe there's a mismatch between the two.
Exactly right.
And then question number 2 here is, how did you determine how much it was going to cost?
Well, that is very interesting to some extent when you move into this. Most of you on the webinar have done some type of financial forecasting and certainly do financial analysis. So when we did it just how you're going to do it, you try and determine what is it going to cost you to deliver the service. So first, the biggest expense, personnel. How many personnel are you going to have? What's their training going to be? What pay rate are you going to pay them? Oftentimes, in order to attract folks into this role, because you're giving them an additional role, you're going to have to pay them more, because most of the time folks want a little bit more. So we did that. We pay our mobile health care paramedics a little bit more than the regular paramedics in our system. So you have all of your personnel costs. You then have to build in your training cost, because all of those people are going to have to be paid when they go to training. Then if there's a cost for the training, so if there's a cost for the course, or if it's a curriculum fee that you're paying or whatnot, sometimes you have to pay for clinical time, depending on the relationships that you have with some of your clinical sites. So you take all those personnel costs combined, then determine what are going to be the vehicle they're going to use. So in our case, they use a Ford Explorer, a Chevy Tahoe. We're actually now looking at putting them in a much different vehicle that isn't as expensive to operate. But what are the vehicle expenses? What are going to be the equipment that you're going to carry, which could make a big difference? Our mobile health care paramedics carry all of the regular advanced life support equipment. So you've got the cost of a monitor defibrillator, bang, biggest item that we carry, huge expense. But then if you're going to do some point of care testings, like we do with our congestive heart failure patients, you're going to need some type of a field lab device. So we use the iStat monitor in our system. The iStat is inexpensive relatively. It's about $9,000 or $10,000. But every time you run one of the tests, it's not like using a little glucometer strip. It's a $25 cartridge every time you're going to run the lab. So you need to calculate out how often do you think you're going to do that type of testing. What's it going to cost? You have a partner that will replace those cartridges for you. So you build that into the model. And then throw in the ancillaries. You're going to have fuel expense. You're going to have disposable medical supplies. So we did that. We did essentially the total cost for running one mobile health care paramedic, the time that we were going to run them, so 2,080 hours or 2,288, however you're going to run that schedule, and then determine what your cost per unit hour is going to be. And then you have to build in there, by the way, the cost for medical control, which has been very interesting because I'll give you an example. In our system, historically, we have paid for medical control based on a cost per transport. Well, for the old model, that worked well because you transported a lot, and that was how you got paid, so it made a lot of sense. In our new model, the medical control is actually more involved with the patients that we are not transporting. So whether it's the nurse triage program, whether it's the community health program, or the congestive heart failure program, or the hospice program, or whatever it is that we're doing, we're contacting those patients, but not transporting them. So to compensate the physician medical director or your medical control authority based on transports becomes sort of silly. So you have to look at a different model for them. So we're going to be hopefully transitioning here soon to a cost per patient contact for medical control, which is a more realistic way to pay for that service. So you build all those in, determine how many patients now can the mobile health care paramedic actually see in an hour. So if your hourly cost is X, you can see one patient every 2 hours. then you have to figure out, okay, so we're going to, just like an ambulance transport, we have to collect X to be able to cover those 2 hours of cost, and now you're off and running. But Mike, I want to mention, and I think we may go into this in more detail. Well, let me stop there and see if you have any additional questions, and we'll talk about, cost versus value in a future discussion later.
Yeah, this is excellent. We do have a value question coming up here, but the other thing that you might consider doing, those of you who've been in this business, but is adding some contingency. If you're doing this on a spreadsheet, you would add a contingency, whether that's 10%, 15%, or whatever your comfort level is, just for the unknown costs that might occur, because in many cases you're going to be signing a contract, so your ability to get out of the contract is going to be limited to 60 days, 180 days, or even 365 days, and so you're going to have the ability to make that happen. And then ultimately, eventually, when you look at how you're going to get paid, there are going to be some patients you don't get paid on, and depending on what your model is on a capitated basis, on a per member, per community basis, if there is going to be a gap, we would somehow in that spreadsheet cover some unanticipated, unrecoverable dollars and put that into the fray as well. It's probably not as clean accounting-wise, but it certainly will give you a cleaner financial picture.
Yeah, we use the term sandbag, but Mr. Hoot doesn't like that. But we try not to put a lot of sand in the budget. But you got to have some sand in the budget, right, Mike?
Yeah, my goodness gracious, sandbags in Dallas and Fort Worth. I don't understand that. So, okay, next question. How do you determine how much revenue you'll be making, charging, and collecting?
Okay, first you want to start, again, back to the basics, is making sure that you're going to, whatever program you're going to enter into, that you have a margin. Because as we often say, no margin, no mission. So when you look at these realistically, you got to make sure that you're going to be able to keep the lights on and keep the people paid and fuel the vehicle. But this is a very interesting and something that we've learned very much the hard way, is that when you determine your pricing, we in EMS, and I use EMS in its loosest terms, quote EMS, unquote, because that's the business that we used to be in. When you look at what pricing we're going to do, we do it based on what our cost is going to be. So if the service delivery costs X, we have to charge Y. Here, we are in a totally different environment. And the economics are, again, totally foreign to what we've normally done. So when you set an ambulance rate, you basically do activities-based costing for the most part. However, in this new environment, under the Affordable Care Act, under ACOs, under bundled payments, you name it, risk-sharing arrangement, the payer for the services will look at the value of what you're going to deliver to them much differently. So it may cost you $40, $50 an hour to keep a unit on duty, but if you're bringing value to a customer that is a decimal point different than that, then do not be afraid to ask for that. We found that with one of our first paid programs, and that we did all the activities-based costing, and it got a little bit pricey, and we went to the customer, and as we were beginning to share with the customer what we thought it was going to cost them to have us do this program for them, they offered twice the amount that we were going to ask for, because for them it was going to save them buku dollars. So if we were successful in that program, each patient was going to save them a major amount of money. So they were able to, in essence, share some of that savings with us, which opened our eyes to a whole new possibility for pricing and revenue generation under these programs. What we can share with you is that for the past 3.5 years, we've done these programs out of our own operational budget, receiving virtually no revenue, to generate enough data to be able to prove to the customers and to build the relationships with the healthcare providers and the healthcare payers and the folks in our community to the point where they were able to now realize that, yes, these programs do bring not only clinical value and experiential value to the patient, but real economic value, and are pretty willing to pay it, to the point now we're on a $36 million budget for our system annually. The mobile healthcare revenue represents about $1 million of that amount right now, and that's a significant departure than where it was 2 years ago when we were spending $500,000 to do this program without getting any return.
That's good news, and there's a lot of hope there in providing all that. So a lot of these revenue charging and collecting, at least in your model, you had some startup which showed a negative number, and there may be others out there that would have the same kind of an experience. I talked to somebody yesterday that they've created a community clinic that they're completely funding on their own for the uninsured and unemployed, and now trying to collect. It's actually in Texas, and trying to, create an environment that might interest a traditional medical provider. We'll assume that's all negative. There's no cash offset to take care of their charge, and there may be other activities like that. But that's not to say that these things can't start off as home runs, especially one of the other areas I'll be talking about here just in a minute or two is possibly looking at grant funds or foundation, what have you. Let's go on to the next question. Next, what are the startup and initial funding options? Well, there you go.
That was a very good segue, Mike. You'd think that maybe you would come up with these questions. You knew a question was coming up next, eh? That was very good. So, and Mike can fill in a lot of these details because he works with a lot of folks, but when we looked at, and we're working with a number of different communities across the country to help them get some of these programs started, there are certainly all sorts of funding options for you. First, internally. Is this something that you're willing to, and you've got the wherewithal to be able to do some self-funding to do this as a startup? If you're going to go that route, one caveat that I would share with you is in any of these mobile healthcare programs that you're doing, someone is economically benefiting from them. Oftentimes it's not you, so you need to follow the dollar and say, okay, so we're going to address the CHF readmission, the hospice, the admission avoidance, the whatever it is that you're going to do. You follow the trail of dollars and see who's writing the check to cover that cost. In some cases it may be taxpayers or Medicaid. In some cases it might be private insurers or hospitals eating the cost or whoever it is. Follow the money and you'll finally get to the place that you want to be at the desk with someone to say, hey, we'd like to partner with you. We think that we can do this program. If we can do a program on a pilot basis or on a demonstration project basis and prove it to be successful, will you be willing to fund it long term? Sustainability is really what you need to think about when you're going into the initial and startup funding options, because a grant is only going to work for so long. Much like Reno, they're getting seed money to start a program, but one of the main objectives of the program that's being funded by the CMS Innovation Center is the sustainability model. Who's going to pay for this when the grant money runs out? So if you go to your hospital foundation, you go to your community foundation, you go to whoever it is that's going to seed some startup money for you, one of the things that you have to do is to figure out how are we going to sustain this once the grant runs out. And you can often do that by partnering with who you think the payers are going to be down the road up front and say, if this is successful, are you going to be willing to pay for it long term? And if they agree, now the bigger question is, how do they define success? And make those determinations before you start. Because what we have found in some of our programs is the folks who said they were willing to fund it in the beginning, once it was proven successful, we came back with data that we thought was great data that showed huge success. And when we showed a 40% reduction in emergency department use in the first 60 days of the program, they said, well, we would define success as 50% reduction, so we're maybe not willing to fund it. So define that up front so everybody knows what the parameters are that you're operating in and what success looks like, so there's no questions at the end when you go back to them and start asking for money. So we talked about hospital foundations, we talked about community foundations. You may find a payer. Dan Swayze at UPMC at eMed Health up in western Pennsylvania got a health plan to do the startup funding because they recognize that it's going to bring them a return. So there's a number of ways to do it. Mike, what are some options that you've seen?
Well, our big player in California is Kaiser, and they are anxious, and on one hand they want to add value to their clients or their members, as they call it, but on the other hand, they want to reduce costs. They see them as inextricably linked. They see one leads to the other. So they have, their eyes perk up a lot, especially anything related to excess emergency department utilization. And I would certainly agree with you that in an initial go-around, you may not have a level of clarity of what the real value is going to be, what you can really deliver. And so you see that as a partnership. The other thing that I see some providers that are making a mistake is they're really trying to go around and share the wealth like a Noah's Ark kind of style. Let's get 2 payers here and 2 hospitals here. And that may work in some environments, but I think in some respects, we do live in an environment where success is represented by something different that one entity has over another. And while we're not necessarily encouraging or discouraging, we work in some of those own environments ourselves. And so I would pick, likely as part of the original conversation we had in the original webinar, a sit-down meeting, a planning meeting that you do so you could have some sense of what the needs are, and then pick one or two of the more proactive players there. And you want to be successful in the beginning. So even if it may mean serving a smaller sample of population, but it's easier to get your arms around, and what they might ask you to do or what you might ask in partnership with them is a little easier to do than taking on all of a Kaiser population. Remember, start small, and then think in terms of the IHI concept, the Institute of Health Improvement concept of leveraging up on a larger scale. Only when you have your success, you've worked out all the kinks and bugs. Think about one that's going to give you success in 6 to 8 months, because that's the one you're going to leverage to other payers, to the original payer itself or foundation itself and what have you. The only other entity that I will indicate is look for entities out there that have significant dollars, and in California they look very much like the old Blue Crosses and Blue Shields when they went private. That is, when they went from their nonprofit status to private. And this has happened in many states. The Attorney General's made them fund a foundation, and the foundations are called different things now. We have the California Healthcare Foundation. We have the California Endowment, which is a huge foundation. We have the Sierra Sacramento Foundation, which is the project we did our primary care, Affordable Care Act work. They didn't really have an axe in the game, but they were willing to provide some seed money to get people together and to create an innovation center to do more than just transport and non-transport options. And they may have some view here to do something different. And the beauty of those entities is they don't really have a large application process. Frequently, they'll come to you with an idea, and if you go to them, they'll say, well, tell us what you think. And they say, well, why don't you go write a letter like that? A one-page, that's all we need. And give us a sense of what the cash flow would be and what your deliverables would be. And you may need some outside counsel for some of that, some mentoring to make that happen. I know we've gotten a bunch of phone calls since the last webinar. And from that, then that's not a very traditional provider, payer, if you will, a financial source, because it's not a provider, it's not a payer, but it does represent some viability there, and they're a convener of these kind of dollars. I think this allows us to move to the next question, which I think is not a question. Juliana, I think we have some questions and answers that are available. Oh, actually, we're in our 30 minutes of questions and answer. Why don't you start with some of those?
Sure, that's great. We do have quite a few questions. The first question is, if we are an agency that currently does not bill or have any billing data or transport data, what can help us in deciding what kind of funding we need for development and funding of the program?
Well, Mike, did you want to take the stab at that transprint data that John is talking about? No, we'll move on a different way. If you don't mind, Mike, I'll take a first stab at that, because we are working with a number of first response agencies that don't bill. Is that okay to start?
Yeah, it's fine by me.
Okay. If you're a fire department, you're a first response agency, you're a volunteer provider, or somebody who currently doesn't bill, you still have utilization data. You've got patient care records. You've got response data from your dispatch system. You've got a number of places that you can begin to mine some data and apply some metrics to. So for a first response agency, they don't transport, so therefore they don't bill. You can bring significant value to a potential customer who would like to pay you to do something different. We'll use the example, Mike, of the Green Bay folks. So Green Bay Fire was approached by one of their hospitals to do some follow-up home visits for recently discharged congestive heart failure patients in their community. So even though that fire department may not bill for service, may not bill for ambulance, may not do a number of different things, the hospital comes to the table and says, hey, I'll pay you $50 every time you go to somebody's house to check and make sure they're doing okay. That's one way that you can begin to do this. Any person who's in an administrative capacity, in whether it's a public agency, private agency, has some good financial acumen on what it costs you to deliver service. and you can use that as a foundation. We've got another organization that we're working with where they thought initially they'd have to add resources to do some of this work. Well, when you really take a hard look at the activity level and the productivity of that particular agency, they realized, you know, we probably don't need to add any other resources, so therefore any dollar that we bring in is new dollars into the system because we're not having to add a whole bunch of costs to deliver that. So be very frank, be very sincere about what your true costs of delivering services. Do you need to add resources or not? In some cases, depending on the model that you're looking at, you may not have to add any resources, but just bring in that additional revenue.
Great, thank you, Matt. The next question we have is...
You know, that was pregnant pause on my part. But, I do have one other comment. You know, we would look traditionally at our 911 providers as being the source for all this, but that is just not necessarily being driven by anything. One of the very first community worker programs in this state that was EMS specific was a first responding agency in Nevada, California, which is in Marin County. And they didn't use medics. They hired EMT-ish type people, and they were non-public safety. And they had a mission in their community about what they wanted their community medics to do, and this was all about wellness. And while there was no offsetting costs or revenue associated with it, they were able to develop a lot of yield with a very low cost and a tremendous amount of goodwill in their community. And so I do, you know, I think both Matt and I want you all to think out of the box and out of the universe and out of the Terraverse or wherever you want to go if you haven't seen Gravity yet, and really start thinking in terms of, you know, what are the different innovative ways? And you're going to see a lot of traditional ways of doing this, but when the cluck for the buck of those are done, well, then we're going to need to move to other venues as well.
And Mike, you're spot on. I want to highlight one other for the webinar participants. There are willing partners today, funding partners today, that we didn't have at our table even 3 years ago or even 2 years ago. And you're going to find those folks are willing to make investments in return for a changing outcome in their economic metric, if you will. And we'll use Mesa, Arizona as an example. So in Mesa, they are actually partnering, the Mesa Fire Department is partnering with the local hospital there to have the hospital staff a nurse practitioner on an ambulance in Mesa. And the sole purpose of that EMT paramedic from Mesa Fire partnered with a nurse practitioner who's employed by the hospital is to respond to all of the low acuity calls in the city and treat and refer patients from the scene. Because the hospital did not want to have all of these low acuity patients come into the emergency room. They wanted to have them resourced appropriately to the right setting for that patient's medical condition. So the nurse practitioner arrives at that minor laceration call, can do the suturing, can prescribe the antibiotic with that patient follow-up and refer them to a clinic for follow-up care and suture removal. And the hospital's paying for that. So don't be afraid to think large and to, as Mike said, think out in the universe, because the universe is much bigger today for us than it was even 2 years ago.
Juliana?
Thank you. The next question is, are there any states that have developed insurance billing codes for community health care at the paramedic level?
Mike?
You know, I'm not sure. Of course, Massachusetts, or not Massachusetts, but Minnesota had the first state approved, and they now are allowed to get Medicaid reimbursement, community paramedicine program, through some of the work O.J. Doyle did up there and many others that worked so hard to get that legislation approved. I believe there may be one other state. Matt, you may have quoted it in a previous webinar. And it wouldn't surprise me, you know, coding is pretty much a function of, A, what Medicare does. There are no special coding for Medicare at this point, and B, what each Medicaid payer does, and they are allowed to use a lot of special coding, and so it's quite possible there is some special coding. Would be hard to find out, though.
Well, and Mike, you're right. Maine has also done the same thing. Now, there's a significant difference, though, and everybody in the webinar needs to understand that just because you may be able to get legislation that says that you can charge for community paramedicine, or like they did in Minnesota, that the state should pay, Medicaid money should pay for mobile health care community paramedicine visits, you're going to find it difficult to mandate or to get legislation passed that's going to increase Medicaid spend unless you can show that they're saving money down the road. That's what Buck and OJ were able to do in Minnesota. They were able to run the economic models. That's what we've been able to do in Fort Worth for our hospital partners and for our payers to say, here's the outcome, is that when one of those patients gets navigated into our program and they get referred and handled in a way that is different, the spend for that patient is X. So why not take X and give us 20% or 10% or whatever the percentage is that the customer is willing to pay in return for saving you that 80%. JAMA, the Journal of the American Medical Association, just published a position paper in February that essentially says that. EMS has been incentivized forever to use the most expensive transportation resource to take the patient to the most expensive cost setting. Well, that's just stupid. The EMS should be paid to navigate that patient to the right place, right setting, right outcome, right cost. And if we're able to do that and do what they do in the UK and Australia and most other countries, then the value of EMS goes significantly up, because now we're able to get paid for things that we didn't get paid for in the past, because we're improving the economics of the entire system.
Yeah, well said. Juliana?
Our next question is, I'm engaged with the health system in a readmission mitigation program that was began as a self-funded pilot, and they have not agreed to any type of funding model. Do you see long-term remaining a large challenge to sell a partnership to hospitals or other payers?
Well, let me start with this. And I do a lot of hospital work as well. And I'm surprised. I'd have to know a lot more about your unique circumstances and what got you where you are, and what the ultimate goal was, and whether there were some commitments made up front that you could achieve certain benchmarks, and you could be willing to do that at no price. But if the other partner, remember it's a partnership, right? Because there's a lot we don't know about these things, and we jump into these things hoping we'll know a lot more. But the ultimate goal is a better, the triple aim from the Institute of Health Improvement, it also includes improving the patient's experience. It's not just on cost. And if that long-term partner is really not willing to become a partner and put real skin in the game, then I would suggest that you don't have a partnership. And I don't know how long, unless you are uniquely in control of lots of dollars that most other traditional 911 and mobile health programs aren't. I don't see how you're going to be able to sustain yourself. Matt, you may have some brilliant ideas there.
Well, and I would agree. I think that, the question, and I feel badly for that person, but the question now becomes, what did you do groundwork in the beginning to begin that collaboration, begin that partnership that Mike talked about? Now, to some extent, the hospitals are, let me see how I can say this politically correctly. When CMS first started coming out with the readmission penalties, there were many pundits in the healthcare system that perceived what Medicare was going to be doing was not paying for the readmission on 30 days. Well, when the final rule was done, that was not part of the deal. So the hospitals are getting funded for that 30-day readmission. However, the bigger issue for them is that they're getting those readmission penalties. So when we started down this road, the cardiologists and the hospitals all said, hey, we're willing to share with you the savings of not having that patient come back because we're not going to get paid for it. There's an expense to us. So it made it very clean. When the final rule came out, after we started our program, by the way, the rules were different. So we had to adapt to that and be nimble enough to go back to the hospitals and work with them and say, okay, the cost savings sharing for the CHF readmission isn't going to work anymore because the dynamics are totally different. But the hospitals all recognize that they want to reduce their overall penalty that they may be getting from CMS for those readmissions. So in our case, they said, just tell us how much it's going to cost, and we'll either do like we do for the nurse triage program, where we all pay a quarter of the cost of the program, or just tell us what it's going to cost us to refer a patient. We'll still pay it because we're going to make that up in the long run, but the cost savings model didn't work. So you need to be nimble enough to know that maybe something has changed in the hospital's environment, that you need to redirect some of your messaging and really ask them, what would it take? What type of a model would work for you to help keep these programs sustained if they are able to show significant results for the hospital system or for whatever the partner is?
And Matt, I love these emails I get from you and the articles and the intent that goes out with them. But just the notion of some of you sitting there saying, "Gosh, I thought hospitals were being penalized for their 30-day readmission, congestive heart failures, and soon-to-be hip fracture, or hip replacements, and things of this nature in 2014." And I didn't really realize that it's an overall penalty on their Medicare payment, and I wonder how much that is. And that's 3% beginning next year and 4% the year after, and it's escalating. And these are things we haven't seen in the EMS industry, which makes us pretty clean for now, anyways. Well, you can find these things out, and these are all publicly documented if you go to cms.gov, and you can find out by hospital and in the region what those numbers are. And if you need some help navigating, then, there are people out there that will help you navigate that process. But the beauty is that the person that holds the most control is the person that has the data. And this is sometimes data that a hospital is going to be thoroughly aware of, the penalty factor, and they're probably doing many, many things right now. That's got their attention. But they may not be aware of the role of mobile health in playing this, and if you can't document that and leverage that by having numbers, and hopefully your numbers is better than their numbers, then you don't have very much leverage. So in an early collaborative, God, we're all investigating, we're all trying to figure out, it's fine, but in the second phase, when you better have real good, strong numbers, and that's actually our next webinar, which is an hour on, show, let's see the numbers now, now that we've talked about all these great ideas. So just put that into your thinking cap. Juliana, how many more questions do you have?
We have about 3 more.
Okay, let's go.
And the next one is, how do you go about identifying ACOs in your area?
Mike, this is all you, my friend.
Yeah, well, thanks to quick step work during a recent webinar, Matt was able to produce that list, but it's as simple as going on to the Medicare.gov website and finding out the current approved ACOs. It's changed just a little bit. Some of the legacy ACOs have dropped out some of the programs. They found that they're not getting the cluck for the buck they were expecting, but there are many others trying to clamor on. And again, an ACO is a risk-taking entity made up of a variety of providers and both physicians and hospitals, and that makeup can vary a little bit. But for some reason we forgot to include the ambulance services as part of this, and we do know the ambulances do control quite a bit of the costs. If we take a patient in, they're likely to get a lot more services than if we didn't take them in, and we don't have a choice under a traditional model. But an ACO could change that model and help us get paid on a per member per month basis. So I don't know what our current status is, but I do believe that's going to be posted with this webinar up on our website, or at least the indication of this webinar on our website, so you'll be able to see at least part of the handouts of this webinar so that you can all see what the current list is.
Mike, did you really say cluck for the buck?
Buck a cluck. I did that once. I said that in Canada once, and the Canadian hospital could not stop laughing. They just thought that was the funniest thing. And what I didn't realize is they don't have a Colonel Sanders there, because that used to be an old Colonel Sanders joke.
Aha.
And they just couldn't believe it, because Colonel Sanders doesn't exist in that country. They may now, but now Tim Jordan's exists there in a very good way, which is our coffee, the ex-hockey player coffee guy. Juliana, do you have another question?
I do. Do you consider the seed money a temporary situation? That is, how long are estimates for if and when Medicare and Medicaid may become payers for the new service line?
Well, Mike, if you don't mind, I want to take a stab at that. The seed money is always going to be temporary. The bigger question that this person asked, which is a great one, is how long is it going to take for Medicare and Medicaid to become payers? Well, we had a significant eye-opening experience last year when several of us had the opportunity to sit down with CMS directly in Washington and have a pretty frank conversation. Now, I will share with you that CMS is very much aware of the mobile integrated healthcare movement in EMS, and they love it because they've seen the improvement in patient outcomes, they've seen the improvement in costs. The challenge for CMS is that, by and large, one of their goals long-term is to get out of the fee-for-service business. And they see the movement into managed Medicare, managed Medicaid, that is the Part D programs in Medicare where these patients are enrolled in the United, the Aetna, the Cigna, the Humana, the Kaiser programs, and they're being managed by an actual payer in a different way, not truly being fee-for-service. They see that as really their role. They want patients into managed programs, they want patients into bundled payments, they want patients in accountable care organizations because it makes it much simpler for the funding of those patients, and it aligns everyone's incentives in a way to improve patient outcomes, improve the patient experience, and reduce costs. So for all of us on the webinar, our focus moving forward is not necessarily when is CMS going to come up with a CPT code that we can bill this for, when is Medicaid going to come up with a CPT code, but how do we skate, as Mike indicated earlier, to where the puck is going to be and start working with the managed Medicare and the managed Medicaid payers who are much more nimble and able to actually just create something that they're going to pay you for to prove value to them so that they will pay you. So if we're going to wait around and wait for Medicare and Medicaid to come up with a fee-for-service, we're all going to be waiting a very long time. But I think also that if we can work with the payers that are growing to be more significant payers in the Medicare, in the Medicaid world that's not direct CMS, that's where you want to start having those conversations with people today, because you can get them to make a decision tomorrow. It takes an act of Congress to get, and we know how well that's working, to get Medicare to start paying for some of these things if they want to make that change.
Good point. And Julianne, I believe you have one more question.
Yes. Do you seek payment from patients, or do you solely focus on insurance companies?
In our system, Mike, we looked at billing patients, and for those agencies on the webinar that bill for no transport, what you may find and what we have found is that it's pretty good money. When you send a $100 bill to somebody, instead of sending them a $1,000 bill for the ambulance transport, most people can write a check for that, or at least a portion of that. So the collection rate's pretty good. If they're willing to pay for home visits, it really kind of remains to be seen. You certainly can. One of the things that we may look at long term is something like a subscription program. So many folks in the webinar may have a subscription program in their system where, for X dollars per year, the household gets their coinsurance, deductible covered, whatever. Consider maybe doing the same thing for mobile health care. So you buy a subscription for $100 or whatever it's going to be for the year, and that gets you, 5 or however many mobile health care visits, and maybe a home assessment for risk of falls, and some CPR training, and some whatever it is. There may be a very good market for that, because not only the patients, but maybe some of the payers would be willing to incorporate that into some of their benefit packages. So there may be some opportunity for doing that.
A lot of bang for the buck.
Or a cluck for the buck, even.
There you go, a cluck for the buck. I just want to remind you that these 2 sessions now will be available for purchase on CD, and there's a discount for those of you that have attended. But it may be there are others within your organization that have not heard this, and we also are promising another webinar on successful programs depending on data, which would be October 23rd, and again, it'll be at the same time as these other webinars. We want to really thank you for participating today and helping us better understand your needs and some of your questions, and then, of course, Matt's brilliance about what has happened in the greater Fort Worth area and what have you. And Matt, once again, thanks for being a good partner in this project.
Thanks, Mike. My pleasure.
Juliana, you want to close?
Yes, thank you all again for joining us today. We appreciate it. Look forward to your participation in our next webinar on data, and also your participation in future Abaris Group webinars. Thank you very much, everyone. Goodbye.